But orthopedic oncology is this nexus between bone and soft tissue benign and malignant tumors and their affectations in the musculoskeletal system. We're often tasked with solving some of the most rare and impossible problems, and some of the problems that Mother Nature really has no intention for any one doctor solving.
Treatment definitely needs a multidisciplinary team. We are the surgical group. We have the medical oncology group who gives the chemo or immunotherapy. We have the radiation oncologist for radiation, but it all starts with imaging, the radiologist, the pathologist to look at tissue on a biopsy, and then we all come together. We meet several times a week and talk about all of our patients.
The most powerful aspect of our care, so for instance, we have a multidisciplinary clinic where I will see the patient with my colleagues, but then we will take the patient's history and their imaging and present it. The folks that have seen the patient will weigh in, but we'll also get the input from all of our other colleagues. And from there, we develop a plan. And so you're really getting the collective intellect of the entire group. And I think from a patient's perspective, I can sense that is comforting to them, and it would be comforting to me as well. You trust your doctors, but it's very nice to have a large group weighing in.
Even though patients sometimes first meet me with difficult or challenging problems, we're always able to put together a plan, meaning both treatment and also expectations and next steps.
The hospital has a very good setting in which we combine the science and the art. So we try to do a lot of research. We do different prospective studies. We try to invent new technology. So you can have all this science, but then ultimately when you make a decision of what is going to be the ultimate treatment, there is something that is personalized about that patient or that individual situation that is the art of the treatment of the patient. And I think we're very good in balancing that and really making a whole scientific analysis, but then be able to bring all the data to a very specific case and execute the artistic part of the treatment.
We're constantly having to innovate solutions, whether they be biologic solutions, using parts of our bodies to mend parts of broken elements of our bodies, manipulating metals to be more adaptive. We use surgical navigation like a GPS to find ourselves in and around the patients and their problems so that we can be as minimally invasive as possible. So we have to be creative, but at the same time extrapolate from the basics.
What I do is not easy, and many people say, oh, I couldn't do that. And I think to myself, but I couldn't do anything else. I really love it, and I'm drawn to it, and I wouldn't do anything differently.
It truly is a patient, family-centric relationship. And being in an orthopedic oncology, it goes on for years. If it's a malignancy, we follow our patients for 10 years.
The surgery itself, the recovery of surgery, the physical therapy, the surveillance period, develop this very deep connection with your patient that when the surveillance time finishes, it's like, how are you telling me that I don't need to see you anymore after 10 years? And you end up developing these very close relationships with families and patients that, to be honest, is the most rewarding aspect of my job.